Good morning, good afternoon, good evening, good night, whatever time it may be when you choose to participate in this lecture. So we are leaving the discussion of pharmacokinetics and pharmacodynamics. We are week 2, lecture 2. This will be broken up again. We'll exceed no more than an hour and 50 minutes for the lecture 2 series, but it's going to all encompass the renal pharmacology. So if it's a drug that it elicits its pharmacotherapeutic effects somehow, some way within the kidney, within the nephron, we're going to talk about it. So your diuretics, your vasopressin or your antidiuretic hormones, your vasopressin antagonist, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, mineralocorticoid antagonist. Those are the drugs we're going to discuss. So let me go to share and we'll just do a general share initially because I want to pull up and I want to appreciate. Let's try to get this out of our way here. I want to appreciate you all to see where we're at. So when we look at this, you can see, remember, don't worry about the weeks necessarily. We're just going to go in order and I'll let you know what's going to be on an exam. So as we're progressing, February 9th will be our exam. Today we're going to start our discussion over the renal system. We'll call it probably 3 or 4 different discussion points, but no doubt we'll start with diuretics is what we will start with. So that's going to be your week 2, lecture 2, and then we'll have lecture 2.1, but each one of them will appreciate a different part of or different drugs that elicit their pharmacotherapeutic activity through the pharmacology within the kidney. So this is where we're at right now, okay? Overview of the renal system and pharmacology. So let's minimize that down. Let's go back to share and stop the share and just go back to our lecture. So here's our PowerPoint right here. I'm going to share that. I'm going to pull it up. So this is where we're at, the overview of the renal system pharmacology. So welcome. What are the objectives? Certainly to have an understanding. This is something you did learn in undergrad in anatomy and physiology, something you should have reviewed and built upon in gross anatomy and your clinical medicine courses, but we will just touch on renal anatomy and physiology. We will discuss the actions of diuretics. That's going to be very much a high yield situation, so you'll know the various classes, which ones we consider high ceiling. Always your loop diuretics there. You just got a test question right. And their mechanisms of action. That's very important for understanding the changes in electrolytes, where it's going to elicit its response. And then certainly understanding water homeostasis, because that's what kidneys do and the function of vasopressin. Arginine vasopressin is your natural hormone in the body that controls that. And in essence, stops diuresis. That's the problem when people drink too much. Oh, I drank a lot, I'm urinating a lot. No, you actually inhibited your vasopressin. So your antidiuretic hormone. So you're peeing a lot and you wake up in the morning with a headache and cotton mouth and all that. So, but we'll talk about water homeostasis because that's a big part of the kidney, including blood pressure. We will discuss some specific disease states that revolve around that, such as diabetes insipidus and the syndrome of inappropriate antidiuretic hormone, and then certainly a big discussion on the renin-angiotensin-aldosterone system. If you understand how the RAS system works, the drug part, it's easy. And it's not only applicable to the kidney, you can apply this to blood pressure, congestive heart failure, multiple sclerosis, multiple different pathophysiological states you can appreciate. We'll briefly touch on the 3 causes of nephropathy. I think you all know them. A drug-related, your non-steroidal anti-inflammatories. That's your number 1 cause from a drug perspective. Your number 1 cause overall is diabetes, type 2 diabetes specific, or type 1 too, they have issues, but diabetes, and then hypertension nephropathy. So all three of those, we have a way to mitigate that or even prevent it from happening. So appreciate it. We'll briefly touch on the kidney stone, nephrolithiasis, and nephropathy that's associated with it, and some common strategies to prevent it. So this slide here, I'll go ahead and maximize it. I don't know why this is hanging up there, but this is for your information only. I do feel this is something you should learn and understand and appreciate, especially in the content or the context of pre-renal acute kidney injury and more of a volume depletion. But it's much more complicated than this volume depletion. Does someone have diarrhea and their serum creatinine up? Look at their BUN to creatinine ratio. Is it more than 20 to 1? And it might be pointing towards an AKI. Does someone have a kidney stone and they have hydronephrosis? This is probably going to be a post-renal. My entire world has been in the hospital. When I see post-renal AKI within the hospital, more specifically, I spent most of my career in the ED or ICU. In the ICU or in a hospital bed, it's not, we don't use Foleys as much. Used to, everybody got a Foley, and we don't do that because it's a nice source. Any plastic and aluminum in the body increases your risk of an infection. So we avoid that at all costs, whether it's an endotracheal tube or a urinary catheter. But my point being is, in the hospital situations where you see post-renal, someone has somehow rolled around in bed and kinked their catheter tube. We don't see it as much because, again, we try to not put urinary catheters in for more than 48 hours. But if you see that, ask, do they have a Foley catheter? And look and see if it's kinked. What is Occam's razor? The simplest solution is probably the answer. And then you have your intrinsic. This is usually your drug-related phenomenon, whether it's contrast media, vancomycin, Zosyn, NSAIDs, the list goes on and on and on. But I would appreciate this and understand it. So we talk about the renal system. So the kidneys filter unwanted waste, right? It's working in conjunction with the liver with those phase 1 metabolic processes and phase 2 processes to make everything more water soluble. We get it to the kidney and boom, we're getting rid of waste. Kidneys also maintain homeostasis in the terms of fluid balance, electrolyte balance, pH balances, while maintaining our blood pressure. So that's very important as well. So some terminology you need to know. When we talk about reabsorption, we're talking about the movement of water or solute from the nephron back into circulation. It's a paratubular capillary that follows the nephron, and you have your afferent, your efferent arteriole, and that capillary follows it through the different portions, the proximal tubule, the descending, the ascending loop of Henle, the distal tubule, and the convoluted collecting ducts. There's a paratubular capillary that follows that, where you're having reabsorption. Now, when we have movement of water solute from the circulation into the nephron, that is referred to as secretion. We have 99% of what we secrete is reabsorbed. The kidney works really hard, so you need to appreciate it. There's your anatomy of your kidney. Here's your renal artery, renal vein. There's your ureter, very important. You have 2 of them, one coming from each kidney, headed to your bladder, then to your urethra, and then mituration, boom, into a toilet, behind a tree, into a field, wherever that may be, you're urinating, right? You're going number 1. But there's your medulla, and then certainly your renal cortex being on the outside. And that nephron is curling in and out like that. And that is your basic functioning unit of a kidney, is your nephron, right? There it is. So it consists of a filtering apparatus, that's the glomerulus, that's incorporated or encompassed by the Bowman's capsule. But I want you to know, when it comes to the kidney, it's composed of approximately 1 million nephrons. That's responsible for filtering the blood and regulating those processes we just recently discussed. To put it all together, homeostasis. And that's going to be water balance, pH balance, electrolyte balance, and certainly a very, very profound effect on your blood pressure. So let's make sure we appreciate that and understand that as we get into the drug. So the glomerulus, you'll see a picture soon. I think we have one down here. In one of these, it's going to be your We should have one. Yeah, there we go. This would be your glomerulus right there, your afferent arteriole coming in, your efferent going out, which is going to follow this. That's going to be that paratubular capillary, but this would be what is called your Bowman's capsule. So when we talk about that, please appreciate that. But you have your glomerulus, tightly tangled mass of capillaries, right, where solutes and water are secreted into the tubules. Okay, this is where we get, when go back to your pharmacokinetic lectures, when we talked about elimination, we talked about creatinine clearance. And in addition to creatinine clearance, which was the Cockcroft-Gault equation. Secondly, we talked about the GFR, the glomerular filtration rate. That is the rate of filtration at the glomerulus. This is how we define how well a kidney is functioning. And they are estimates. Remember, when we talk about creatinine clearance, that's a calculation using the Cockcroft-Gault equation. Not as accurate when you start getting at more renal dysfunction, and most of your drugs are going to be dosed, renal dose adjusted, based on the creatinine clearance, based on study. But remember, with the GFR, we talked about the CKD epi and the MDRD. And if you remember, we said these aren't very accurate when your creatinine clearance is over 60, but they become more accurate when you have an underlying level of chronic kidney disease or a GFR creatinine clearance less than 60. You're starting to see GFR calculations incorporated into newer drug dosing recommendations when there's a level of renal insufficiency. And we gave those examples in the lecture. So you'll check your creatinine to establish what a patient's GFR, but that creatinine, it's simply that metabolic waste product that is filtered at the glomerulus and is minimally reabsorbed. So if it's not filtered, your glomeruli, that nephron is not working in that Bowman's capsule. So that's why it is a good metric for establishing the level of renal function or dysfunction that is going on. But as you know, we just talked about those three equations we use, the Cockcroft-Gault to estimate creatinine clearance. To estimate the GFR, you have the CKD epi or the MDRD. So we use these to calculate our drug dosing. So the nephron itself, this is where we are filtering plasma. We have a lot of reabsorption of secreted substances, right? That's going to go on. How aggressive is that reabsorption? Well, the human, from an ultrafiltrate perspective, when you think ultrafiltrate, that's how much urine we make. You'll hear when you get to work in the hospital, and if you're working with dialysis patients, or more specifically, let's say you're doing the nephrology rotation, which we have several very nice nephrology rotations within Hardin-Simmons or program or PA program for your clinical year. But sometimes when the patient goes to dialysis, they're not necessarily trying to pull off metabolic waste all the time. Sometimes we got to pull off fluid for whatever reason, and that's the ultrafiltrate. So we'll have ultrafiltration. That's the urine production, and we can control how much we produce within that artificial setting of hemodialysis or whatever it may be. But you, as just a general person, you're going to make about 120 mils every minute. Think about that. Think about how much energy that requires, especially in the context of the fact that only 1 mil per minute of urine is produced. Now, I want you to know, for the context of it, you should really make 0. So if you really want to know that your kidneys are working in the context, you want at least 500 mils of urine per day, okay? But when you look at it, the kidney consumes about 7% of total body oxygen, right? That's the intake, despite the fact that the kidneys make up only 0.5% of body weight. So anything you do that affects the kidney, you can see it can potentially create an ischemic or a mismatch of oxygen demand versus supply. And this will come into effect when you aggressively diurese a patient, specifically with loop diuretics. Those are the most potent class of diuretics we have. That is that's the class of diuretics that are referred to as high saline. So you need to appreciate that. And a lot of times you'll see that when you're aggressively a patient with decompensated congestive heart failure, you'll aggressively diurese that individual. and you'll see a bump in their serum creatinine. Oh my gosh, their serum creatinine's going up, but that's not necessarily a bad thing at all. So it just means that the kidney's having to work overtime. Now, you certainly want to keep your eye on it, but it's expected. It's expected. So keep that in mind and just appreciate what all the kidney, the work it has to do to keep us in what I like to call dynamic equilibrium. As far as the urine output, I like to I don't know. It varies for adult. For like if when I'm working with my NICU babies, I like 1.5 milliliters per kilogram per hour. That's what I go for. When it comes to the adult, it's more of just can I have at least 500 mils a day? If you're making more than 500 mils a day, you're not oliguric, zero's anureic. We're getting some filtration. Might not be what we want, but we're getting something. We're getting something. So keep that in mind. Okay, very important. When we talk about drugs, there are 5 functional zones where we have active reabsorption or secretion of ions, water, glucose, amino acids, drugs, whatever it may be. The first part is the proximal convoluted tubule. When it comes to drugs, a lot goes on here. Some of you might be aware of the SGLT2/1 inhibitors, empagliflozin, etc. This is where these medications actually work. A lot of your diuretics work here. Mannitol works here. Acetazolamide works here. Thiazides enter here. They elicit their effect on the distal, but they enter here. Then you have the descending. Then you have the ascending. That's where your loops are working, your distal convoluted tubules, and then your collecting ducts. And that's when more of your potassium-sparing diuretics come into play. But it's important that you appreciate all 5 of these zones because they play a role. Now, this is a very busy picture. Sometimes I'm hesitant to share it, but I kept it in here because it does tell a story. Excuse me, I'm still having allergy issues. I'm going on about week 5. I don't know what it is in this area. When I lived in Lubbock, it was the Jennings season. Abilene was cedar fever. I'm not too sure here in Wichita Falls. But when you look at the nephron, so this is your afferent arteriole coming in. There is your Bowman's capsule right in this area. There's the glomerulus, those tightly wound capillaries. This is where the filtration starts. This is that paratubular capillary we're talking about that follows along. But this right here, this part, this would be your proximal tubule. And I want you to look at what all is going on here when you look at what's going in and out of the capillary into the filtrate, if you will. There's a lot going on, and if you follow it all the way through, you can see at different portions of the nephron, there's different levels of secretion and then reabsorption. Remember, secretion is what's going into that tubule. But I like this because of the color schematic where angiotensin 2 works. Why is that important? Because we're going to talk about ACE inhibitors, angiotensin converting enzyme inhibitors. You're going to elicit effect there. Aldosterone stimulated. We're going to talk about aldosterone antagonists, such as spironolactone. What about your antidiuretic hormone? Vasopressin, desmopressin, someone who has nocturnal enuresis. We're going to talk about that. You see where it works and what it does. More importantly, what does it do if you re-inhibit it or if you inhibit it? The sympathetic nervous system, this is very important that your juxtaglomerular apparatus, when you're beta blocker, you always think the beta blocker works on the heart. No, when you're having sympathetic outflow for whatever reason, that can be a detriment. And what if we can block that at the level of the JGA here? We decrease renin, and when you'll learn, we're not there yet, but what you're going to learn is when we decrease renin, we decrease aldosterone and angiotensin, and we decrease sodium and water reabsorption and volume expansion and fluid overload. So we decrease the blood pressure. We decrease the work of the left ventricle in congestive heart failure. So I think you can see where we're going. Now, that might not have made sense to you right now, but when we're through with this lecture series, it will. Okay. So that's why I like this, because it gives you an idea of what's going on at the different parts of the nephron. So from your textbook, this right here is your proximal tubule. You can read the specifics there, but a lot of your water is reabsorbed. because it's going to follow the sodium. This is where you can see, okay, we can start making some differences here. By blocking sodium reabsorption, we're going to block water reabsorption, and you're going to have a diuretic effect. And that's where carbonic anhydrase inhibitors work. Mannitol works at that point, so you'll get it. But you can see here, there's a lot going on at this area of this level of the nephron. Again, your afferent arteriole would come in there. There's that glomerular apparatus right there, Bowman's capsule, and it's going out and it's following along, right? But you can see in the proximal tubule, glucose, amino acids, sodium, potassium, water exchange. There's a lot going on at that area. So you know if you give a diuretic or a medication that works here, you're going to have an effect on these electrolytes and these processes. So it's important to keep along. This is where blood urea nitrogen from an amino acid perspective would play its role in excretion as well. But you can go through and look at that and see where various diuretics would work. You know that loop diuretics, or you will shortly, work at the ascending loop of Henle. So you can see the effects is going to be on sodium, potassium, and chloride, but there's also some effects on calcium as well. Loop diuretics increase the excretion of calcium. So someone who's hypercalcemic, we can give them high rate of NS and NS bolus possibly, and then at the same time we can chase it with some furosemide IV, and maybe someone who has metastatic bone disease. It's a good way to dump calcium very quick. But then you're saying, okay, so that could possibly increase your risk of renal stones. Well, if you're predisposed to it, yes, you can see, as I like to say, no good deed goes unpunished, but we'll talk about that. So here we go. There's two pictures here. This is from the 7th edition of your textbook. You all had the 8th edition. Not much changed. I put them in there because some like the other graphic better than the new one, but to me, they're the same. We're going to work through each level of the kidney. Again, this is your blood flowing in the afferent, this is the efferent, or vice versa. This is that glomerular apparatus, those tightly wound capillaries, and then this is your drainage or your filtrate, okay? This is your filtrate, the fluid that would if it stays in, it's not reabsorbed, its end game would be urine, right? Going to the bathroom. So you can see the proximal tubule. Distal tubule, right? Proximal closest to the Bowman's capsule. Distal furthest away. So this is nice because it's going to tell you where, like acetazolamide, this is a carbonic anhydrase inhibitor. This is where it works. Thiazides and thiazide-like diuretics work in the distal tubule, but they enter the process within the proximal tubule. This will come into play because for thiazide diuretics, not thiazide-like, if your creatinine clearance is less than 30 from a diuretic perspective, they lose their effectiveness or their efficacy. But we use these for blood pressure, and your creatinine clearance less than 30 is not affected. It does not affect the blood pressure lowering abilities of a thiazide. But this is where it would get into the process of getting to the distal tubule to elicit its pharmacological effect. Certainly you have your ascending loop of Henle, so just think loop diuretics. These are the most potent. Really, we only use loop diuretics for one thing, and that is to remove fluid, whether it's just over time with the low daily dose, or someone's decompensated with congestive heart failure and we got to give a higher dose to remove fluid. We're going to talk about that. But these are what are going to be referred to as high ceilings. I'll tell you the ceilings now if you want. The ceiling dose for furosemide is 400 milligrams. So you really can't give more than that. You start increasing your risk of ototoxicity when you do that. It works on the hairy cells. And I think it's an endolymph. I have to look it up. As we go through, I'll look it up and find it. I got my phone here with me that I could Google, but I think but you need to know that's when the ototoxicity kicks in. That's one of the side effects of loop diuretics. For your bumetanide, your high ceiling dose is 10 milligrams. And then torsemide is just always think half of what furosemide is. The highest dose you could give on torsemide is 200 milligrams. So keep that in mind. And then when you get over to what we call your potassium sparing, these are potassium depleting diuretics. You lose total body potassium, spironolactone, amiloride, and triamterene. These are what we call potassium sparing diuretics. Now, none of these have a very good-looking diuresis profile. And amyloride and trampoline are really just adjuncts for other issues. It's really just to offset the hypokalemia from loops or thiazides. Spironolactone, weak diuretic, retains potassium, huge pharmacotherapeutic benefit when it comes to its pharmacology in treating congestive heart failure. We are not using it for a diuretic. We're using it for the fact that your endogenous natural mineralocorticoid is aldosterone, which causes sodium and water retention, which can be a detriment in someone who has congestive heart failure. We do it because it's an antagonist of aldosterone and it inhibits the reabsorption and maintains the secretion of sodium and water, and therefore it decreases what? It decreases, for the most part, preload. Uh, Again, if it doesn't make sense to you, it will, but at least we're starting to appreciate that type of discussion as we go through the diuretics. So, okay, very good. Just keep going. Just two different slides you can look at where they work. And this is nice on the second, the strongest diuretic acid, the strongest diuretic action, the loops, etc. So, but we'll go through this. So here are the diuretics. Your main classes, your thiazides. Think blood pressure. Think blood pressure when you use this. Think metolazone or indapamide as well. If you have loop diuretic resistance, you're getting up around 200, 300, 400 milligrams of loop diuretics. You can add metolazone 5 to 10 milligrams to it, and sometimes that will help you overcome a level of loop diuretic resistance, regardless of your GFR. Then you have your potassium-sparing diuretics. Remember I told you amyloride and triamterene? Think of those as adjuvants. We really just give those because they're potassium-sparing, and your loops and thiazides and carbonic anhydrase inhibitors and osmotics cause you to lose potassium. Well, we try to offset it by giving triamterene or amyloride so you don't have to take potassium supplementation. Your carbonic anhydrase inhibitors, I can tell you some personal stories on that back when I used to be a big mountain climber and hiker, but in some cases, climbers. I used it for high mountain sickness one time. I will never make that mistake again. The side effects were horrible. We'll talk about it. But diuretics, different uses, but where goes the salt, goes the water, right? So thiazides, what I want you to know, high yield, we use these for hypertension, not their diuretic effect, okay? They're not one and the same. The thiazides do cause some vasodilation after 3-4 weeks of taking these medications. It's actually hydrochlorothiazide if you don't have any confounding type of diagnosis and you have high blood pressure, there's a good chance you're going to start your patient out just on hydrochlorothiazide, especially if you only need maybe a 10, maybe you'll get 20-point decrease along with diet and weight loss. You can pretty much get a patient's blood pressure controlled. Now, if you need to lower it more than 20 points and they're not making progress from a diet perspective or a weight loss perspective, a lot of times you're going to need 2 drugs. But if it's a diabetic, we always go with an ACE or an ARB because it prevents progression or it can mitigate progression to chronic kidney disease in those populaces. So, but yeah, it's a drug of choice for hypertension in the other person, otherwise healthy person. Loops, this is for edema. This is for diuresis. You do not use a loop diuretic for blood pressure. When you give copious amounts of a loop diuretic when someone comes in the hospital, by virtue of depleting their volume, you can have a decrease in blood pressure, but a lot of times you'll have a corresponding increase in heart rate. I didn't say to the point of tachycardia, but it's a compensatory mechanism. But our loop diuretics, it's going to be something when someone just needs to take 10 to 20 milligrams because they're a CHF patient, or they have stasis edema for whatever reason, they may have to take a low dose at night. But when someone comes in the hospital with pulmonary edema, or they're fluid overloaded, or decompensated congestive heart failure, you're going to be given a loop diuretic. You're not going to give a thiazide. You're not going to give carbonic anhydrase inhibitors. We just had a study on IV acetazolamide and CHF, and didn't really produce the results we wanted. Your loop, IV loop, specifically furosemide or bumetanide. Most hospitals are going to go with furosemide. You might be familiar with the name Lasix. I should say that. Some of you might be more familiar with that term. And there it is. That's what you're going to use. Now, your potassium sparings, remember, we talked about that. We'll get into it. Your eplerenone and your spironolactone, that's a little bit different story. We're not using those as their diuretic effect. We're using it the fact that they are an MRA or a mineralocorticoid antagonist. That's a big difference. Cambardic anhydrase inhibitor is a very good drug for glaucoma. You can use it orally for glaucoma. We usually use it in the form of an eye drop. You can also use it for mountain sickness because it increases the excretion of bicarb, and you get a metabolic acidosis, which the only way you can compensate is breathe faster, breathe off your partial pressure of CO2, blow it off. And so without knowing, it makes you hyperventilate to a certain degree, so you have more oxygen or gas exchange. That's how it works for acute mountain sickness or to prevent it. But again, as you're going to learn, nasty metallic taste, the paresthesia is just you tingle all over. It's just no bueno, no good. So let's get into our drugs. We're going to start with mannitol, not really a big one we talk about. So this is referred to as an osmotic diuretic, and you need to know that. That's what if I said which drug is an osmotic diuretic, it'd be mannitol. So how does that work? Well, the simplest way to put it is it increases the osmolarity of the plasma. So let's look at it. Increases osmotic pressure. You all took general chemistry, so we're going to have solute going from low concentration to high concentration to dilute it, but it increases the osmotic pressure in the glomerular filtrate, inhibiting tubular reabsorption of water and electrolytes. So it's going to continue, because of the osmotic gradient, to pull or secrete water into the filtrate. So we can use it. You're going to see some increased urine output, but overall, it's a weak diuretic. You would not use this therapeutically just to use diuresis. So what would we use it? We don't use it for diuresis, but we will use it for sebral edema. This is my biggest. We don't use it as much as we did hypertonic saline, especially the 23.6. We don't use it where I work now, but when I worked in an 80-bed neural ICU at UC, we would, in that regard, we would use, this is back in the early 2000s, we would use the extremely hypertonic saline pushed through a central line, just 10 mils to get the same result. But we will use this some. You see it at most institutions will have it readily available if needed, and it will be used for cerebral edema. So those who have, for whatever reason, increased intracranial pressures, and you got to keep in mind, we like to keep those less than 25 or 20. When someone has a profound head injury, and you're going to learn this as you go, you have what you call cerebral perfusion pressures. And when your cerebral perfusion pressures drop, and think of intracranial pressure, so you have capillaries bringing blood flow, perfusing your brain. Well, if you have intracranial pressure, what's it doing? That pressure is pushing against those capillaries and it's closing them. So just by default, it's because of the pressure, it's snuffing out oxygen being delivered to vital brain tissue, right? And that can lead to herniation and death. There's nowhere to go. Remember, the brain is encapsulated, so there is nowhere for the brain to expand. So the thought is if we can pull fluid off the brain, intracranial pressure will be decreased, and it is, and we can maintain our cerebral perfusion pressures. We like to keep them around 60, but even one precipitous drop down to 50 or 40 can have a fatal effect. So you will see, if you work in an ICU with brain injuries, you will see the combination of mannitol and hypertonic saline utilized for these patients. We also can use it for acute glaucoma, for decreasing intraocular pressures, and there's several different strategies. But so it does increase renal blood flow, so it's going to increase your glomerular filtration rate. We talked about increased osmolarity of tubular fluids, which can cause diuresis. So boom, there you go. But it is inert. It's a low molecular weight, pharmacologically inert osmotic diuresis. It really doesn't work. It's just, we're doing chemistry. It has really no other effect on a receptor when we talk about the receptor phenomenons. Not absorbed orally, so you have to give it intravenously. We usually give it Well, it's hard to give it. You don't necessarily give it IV push unless it's ICP because it can have some effects on pressure, but it's very thick. It comes in a 20-25% solution, but we would never use it in a patient who had congestive heart failure or pulmonary edema or someone who had active cerebral hemorrhage. We wouldn't use it. But again, we're mainly going to use it for that reduction of ICP and cerebral edema, intraocular pressure, so on and so forth. The dosing of it, it's usually 1 to 2 kilograms infused over 30 to 60 minutes. I'm not going to test you over that. If they're responding, we can bump it up to 1,000 milligrams IV. I guess that would be your high dose if you needed to give something now over 60 minutes. But you'll see it. It's a 20-25% vial, 50 mils, and we can go from there. So you can get some hypotension from that if you push it too fast. Sometimes you can have a compensatory hypertension. You drop your blood pressure. Remember, it is not binding any receptor. It is messing with the gradient of fluid transfer into the filtrate. So keep that in mind. So sometimes you can have what it's going to be a sympathetic response of fight or flight, and that's going to activate aldosterone. You can see how you have to be very careful what you do with these drugs. Then, of course, if you did have tachycardia, that's just going to be a reflex phenomenon for changes in fluid volume. When you lower your fluid volume, there's less volume to oxygenate, so your heart has to pump faster. What happens when you go for a jog? If you're sitting at your desk right now, take your pulse. It's probably 60 to 90 for most of you. Now go climb 10 flights of stairs and tell me what it does. When you need to have more oxygen perfusion to an end organ or tissue, you increase the heart rate. That is how we used to handle heart patients before we got more fancy ways to monitor them. We would pace them at DDD at 80 beats per minute. If they weren't perfusing, we would just simply increase it to 100, right? So using simple physiologic properties for pathophysiologic states, correct? Okay, so we talked about mannitol. We're done with it. I spent way too much time on a drug some of you will never use, so I can't go back. So now we're going to jump into the thiazide and the thiazide likes. Now, remember, the thiazide likes are going to be your indapamide or your metolazone. You need to appreciate that because those are the two that you could actually use for a diuretic perspective if you wanted to, with the creatinine clearance being less than 30. That can't be said for hydrochlorothiazide, well, the other ones that went into it. Your big ones are going to be hydrochlorothiazide. It's going to be your number one in chlorothiazide. Those are your two big ones you're going to see. So yes, from that perspective, but these, when you look at them, they enter at the proximal tubule, but they elicit their effect at the distal tubule. So this is very important. This is what you want to know. So, but in essence, it inhibits a sodium chloride symporter in the distal convoluted tubule. So inhibits reabsorption of sodium and chloride. What is water going to follow? Sodium. So there's your diuresis effect. There's your increase in your filtrate. So this is going to occur in the distal convoluted tubule, and you're going to result in retention of water within the tubule. So this is very important right here. You need to know this. This is the most common used diuretic for the treatment of hypertension. So we don't use it to decrease volume. That's not what we use it for. So the effects on electrolytes, you are going to see some natriuresis. You're going to see some increased excretion of potassium. That's very important. You're going to see a decrease, and I need you to know this, you're going to see a decrease in excretion of calcium. So if someone had a history of kidney stones and you wanted to decrease the amount of urine calcium, you could give them a thiazide, right? So this has a direct distal tubular action, as well as an increased absorption of calcium. So you do that. You get an increase in magnesium excretion. So sodium, magnesium, potassium loss, and your plasma uric acid levels, and that's very important, increases. Why is that important? A patient who has gout and they're otherwise healthy and you need to lower their blood pressure 10, 15 points, and you think, I'll use hydrochlorothiazide. Well, if you increase their plasma uric acid levels, you could exacerbate maybe a gouty attack. So that might not be your ideal drug of choice, but most widely used, remember, it's not diuresis. That's a secondary therapeutic effect. These are low ceiling diuretics. The only high ceiling diuretics we really have are your loops. So with the loop diuretic, as you increase the dose, you get a more profound effect, but increasing the dose of these medications, thiazides, that's not going to be equal to increased diuresis. So keep that in mind. But the chronic use results in the loss of that diuretic effect. So we use them for blood pressure. So we use them when you think of these medications. I want you to think of first-line antihypertensive if the patient doesn't have a confounding reason to use another medication, such as a beta blocker or an ACE inhibitor or an ARB or a calcium channel blocker. We'll talk about that. But the peripheral resistance is certainly reduced. With long-term therapy, give it 2 to 3 weeks to start working, but you're going to get a relaxation of arteriolar smooth muscle. So when you think about it, initially you are going to get that decrease in that extracellular volume. So, okay, whatever. But then there's going to be a compensatory mechanism that's going to restore the extracellular volume. You're going to lose your diuretic effect. But again, remember, you're going to get that long-term blood pressure effect that's going to be due to a decrease in that peripheral vascular resistance. And when you do that, that's going to have that indirect effect of negative sodium balance, alternating the wall compliance. It can go, we can get into a very, very detailed. If you're a pharmacy student, I would be making you understand the direct effects of activation of calcium activated channels, potassium activated channels, hyperpolarization and relaxation of vascular smooth muscle. No, I do not feel like as PA students, you need to know that level of knowledge. You just need to know where is it working, how is it working, and why, the why. It's kind of like the Krebs cycle. We all learned it, right? You don't need to know the big details, but if you understand what electrolytes are involved, where your deficiencies may occur when you give a drug and how it's going to work, then you'll know how you can use it. For example, if someone has gouty arthritis, you probably don't want to use a thiazide because, as I says, it causes reabsorption of uric acid. That's no good. So there's its mechanism. We talked about that, inhibiting the sodium chloride cotransporter, distal convoluted tubule, decreases reabsorption of sodium with an increase in sodium chloride in the tubular fluid excretion. And as we said, where sodium goes, water is probably going to follow. So mechanism, though, I mentioned this is the point on the dependency on the proximal convoluted tubule. So you can get a disruption or a decrease in efficacy if you have a decrease in renal function, specifically defined as a creatinine clearance less than 30 mils per minute. You're going to lose whatever diuretic effect you have. You're going to lose it for a thiazide, not for a thiazide-like. You don't necessarily lose the antihypertensive effect, so that's very important. Now, you need to also appreciate that drugs that decrease renal blood flow, your non-steroidals, they're going to inhibit prostaglandins. What are they going to do? There's your afferent arterio in the normal state, right? Flowing in when you give an NSAID and you inhibit prostaglandins that say you give your NSAID, so let's say plus an NSAID, and you're going to get this. You're going to get a constricted, or you're going to get less blood flow, and you're going to have a compensatory effect on the back end because your efferent arterio is now going to constrict to increase the perfusion pressures of the glomerulus. And what did you just cause? Hypertension within the kidney, within the glomerulus. And what did I say was the number one drug cause of nephropathy? NSAIDs. And now you know. We'll talk more later. So thiazide, decrease urine calcium excretion. So calcium is being reabsorbed, so that may be something to consider in someone who has a history of renal stones. So in the distal convoluted tubule, you're going to have reabsorption of calcium, but the indication is mainly hypertension Heart failure, only if you're loop resistant. And in that case, use metolazone or indapamide. You don't need to necessarily use, you can use chlorothiazide, but a lot of times you're not having very good perfusion of the kidney anyway. So my recommendation would be, if you're having loop resistance, you're up above 250, 350, the max of 400 of Lasix. That's when I would come in with metolazone, specifically a 10 milligram dose times 1, and see what it does. But they would never be used as monotherapy in someone who was loop resistant with congestive heart failure. It would be adjuvant. It would be an add-on for resistance. Hypertension, people. Hypercalciuria, so it can help you decrease oxalate stones, right? So because you have reabsorption of calcium, so something to keep in mind. Okay, so adverse effects, your most common is going to be hypokalemia. The 12.5 to 25 milligram dose, it's not going to be as profound, as aggressive as, say, a loop diuretic. You will get hypokalemic on a loop. You need to make sure you're aware of the hyponatremia. This can also be due to anti-diuretic hormone elevation. We'll talk about that later. We talked about avoiding in gout. Okay, so avoiding gout. The hypercalcemia, again, Lasix will cause you to excrete, or loop diuretics will cause you to excrete calcium. These cause you to reabsorb. So if you have a history of oxalate stones, it could be a benefit. If you have hypercalcemia, you probably would want to hold your thiazide diuretic or not stop one. Volume depletion is going to be very rare. A lot of these drugs will have an effect potentially on metabolics, in this case, an increase in glucose and LDL triglycerides. Now, if you do the potassium depletion, by the way, it reduces insulin secretion from beta cells in the pancreas. That's why you can have an increase in glucose, and that can lead to potassium depletion. Okay, so that's where that comes from. So very good. So let's keep moving on. Clinical pearls, your hydrochlorothiazide will be abbreviated many times as HCTZ. This is can be used as a singular agent. Many times it will be used in combination, right? So that's okay. We talked about hydrochlorothiazide and chlorthalidone not being effective in chronic kidney disease if your creatinine clearance is roughly less than 30, but your thiazide likes do work. So your metolazone and indapamide do work. You do need to follow up and check your serum potassium after 1 to 2 weeks. Very important, because you are going to excrete potassium. And then be careful with products with K that are sparing sulfa. This is very important. You're going to get warnings if there's a sulfonamide allergy, like Tobactrim. It's a different moiety. So if a patient has a sulfa allergy, it is certainly okay to use these medications. So keep that in mind. And trying to make sure there's no other pearls. And then here's some counseling. Remember, when you use it for blood pressure, make sure that the benefit, that's going to be in 1 to 2 weeks, not overnight. Okay, so very good. So let's see where we're at. Okay, I'm going to stop my share right here and see where we're at to make sure our timing is good. So recording, I'm going to pause the recording real quick, so I'm going to go get a glass of water. Okay, recording resumed. I started this at 2:40. We're 3:28 again, trying to appreciate your time. So let's go back to our share. Oh, where were we at? Look familiar? Looks familiar. Okay. Here's where we were at. So we were at loop diuretics now. Let's see. As we talk about loops, again, this loop diuretics, we pull fluid. That's what we're using these for. And that's pretty much all we're using for when we talk about our loops. So also referred to as high ceiling. The more you give, the more of an effect. So sometimes you do have to give higher doses. That's the beauty of it, is you can give more if you need to, but these are going to work in the thick, you may hear it referred to as the thick ascending loop of Henle or the loop of Henle. These are going to inhibit inhibits a sodium potassium chloride co-transporter in that thick or that ascending loop of Henle. So we typically in the hospital, if a patient is decompensated or we need to pull, we're going to give it IV administration. And this is certainly going to increase systemic venous capacitance, no doubt, and decrease left ventricular filling pressure. And a lot of that can be attributed to prostaglandin mediated effects. We're not going to go into it in that detail, but we don't use these for blood pressure. We use these just to pull volume. That's what we're using them for. They don't have the same effect on blood pressure over time that you will see with the thiazide diuretic. Now, it's like, well, I've seen patients get 80 milligrams of Lasix in the ED and their blood pressure drops. Yeah, that's because they just dumped out a liter of fluid over about 4 hours. That's a volume issue. It's no different, but you'll see they'll get tachycardic. That's no different if someone goes and runs a marathon and they sweat, their blood pressure is 90/50 and their heart rate's 120 and they need volume, right? So volume resuscitation. So here we go. Okay, why is it not moving forward? There we go. So, and these are your main products. Now remember, when we talked about what is the ceiling of these, so with furosemide, your ceiling is 400 milligrams. With torsemide, it's just 50% of that at 200. That's the max dose. Bumetanide is 10, okay? From a PO perspective, an oral perspective, Lasix has the lowest absorption and F value of about 0.6. When a patient is in decompensated congestive heart failure and they have associated bowel edema, which is going to come, the F value can get as low as 0.3. That's why oral Lasix, when a person gets into decompensated heart failure, they have to go to the heart failure clinic. Now, torsemide, its F value is anywhere from 0.8 to 100. So that's something you really need to appreciate, because I'm a fan of having that, of using that. Because when you do talk about its absorption, it can be anywhere, 80% is good. That's very good. Bumetanide, I'm not too sure about that. That you don't see a lot of oral Bumex. You will see it if someone's not responding to IV Lasix. Don't be surprised if you see as you're learning, when you're going through your rotations, you see that kicked up to an IV Bumex. But they work in the ascending loop of Henle, and we talked about its mechanism, inhibiting that co-transport of sodium, potassium, and 2 chlorides. You know already that one of the biggest side effects is going to be hypokalemia. You lose potassium, right? Potassium depleting diuretic. So keep that in mind. But it's going to be working on that thick loop of Henle, as we talked about, and there's a lot going on there. So let's talk more. Excretes sodium and potassium. I put this in red. If you're giving someone high doses of furosemide or any of your loop diuretics in the hospital, you're going to need potassium supplementation. The same can be said if you're giving them an oral loop diuretic on the outpatient setting, 10, 20 milligrams daily. They're probably going to have some type of potassium supplementation, unless you have something that's offsetting that. You may have some of your patients on some potassium deplete or sparing diuretics, like spironolactone for congestive heart failure, or an angiotensin converting enzyme inhibitor, or an angiotensin receptor blocker. So keep that in mind and appreciate that. But always the ethacronic acid, I think you can still buy it. Haven't seen it in years. We had a furosemide shortage, a big one about 10 years ago, and we were able to get a few vials of that, but it was few and far between. So keep that in mind. But the indications, this is very important that you appreciate this and understand. We're using this for moderate to severe edema. So this is going to revolve around volume. It is the most potent. Your loop diuretics. When it comes to pulling volume or diuresis, this is the most potent. So it's certainly going to be a benefit in someone who has congestive heart failure, and we need to decrease the preload. They are volume overloaded. So, or someone who comes in with acute pulmonary edema, flash edema, we're going to be using that as well, and you can titrate it to effect. And we will give these as continuous infusions sometimes. Hypertension, no, we did not do that. Ascites due to cirrhosis, when a patient is having profound ascites, it will typically be combined with spironolactone. When a patient has cirrhosis, the renin-angiotensin-aldosterone system is shifted into high gear. It is just a hormonal nightmare, and there is a lot going on. There's a lot to decipher. There's a lot to digest. Too much for us to go into during this semester or either one of our courses, the spring or the summer. And then another one, remember, what did thiazide diuretics do to calcium? You had reabsorption, right? Well, loop diuretics prevent the reabsorption. So we can actually use them in hypercalcemia. And one place is hypercalcemia of malignancy, which can be seen when you have metastatic bone disease of various carcinomas. So we will use it in combination with the large volume of an IV fluid. Sometimes it is NS to help excrete or secrete potassium. So you got to be careful, though, in the setting of eukalcemia, the patient is not hyper. So so you ask yourself, okay, this was actually a good point. What if they're not? Do I need to supplement calcium just like I need to supplement potassium? And the answer is no. It's only effective in the setting of hypercalcemia. In the setting of eukalcemia, your serum calcium is normal. Excreted calcium will be reabsorbed in the distal convoluted tubule. So I think that's something very important to appreciate, because if I don't emphasize that, I could see why you would think, oh, well, you said we need to supplement potassium because it's a potassium depleting diuretic. And not only that, it's the most potent potassium depleting diuretic. And if you don't do it, they're going to get hypokalemia. If you get potassium less than 3, you really start having issues. You have the quote unquote U wave instead of the spiked T wave, right? And we could go on and on and on. No, in the setting of eukalcemia, you will have reabsorption of calcium. This is going to be in the setting specifically of hypercalcemia. And hypercalcemia many times is due to malignancy, but not always. Not always. There's a lot of stuff that's crazy that, again, when y'all start learning about end-stage renal disease, especially when you get to stage 5 and needing dialysis, the parathyroid hormone, the master gland, and all that stuff is hypothalamus will just wreak havoc on things that are going on in the body. So keep that in mind. Absorption, we talked about furosemide. Unpredictable. When you are in decompensated heart failure, it can be as low as 10%. Yeah, high saline diuretic, but now, variability can be 40 to 60, as low as 10 when someone's in decompensated heart failure. That is specifically due to the edema of the gastrointestinal tract. Now, your duration of action is going to be around 6 hours. Hence, that's why it's called Lasix, lasts 6 hours. So keep that in mind. But it is a rapid onset. When you give it IV, your onset is going to be within 5 minutes. Your duration when you give it IV is only going to be about 2 hours. So I think you do need to appreciate that. You may need to give more or whatever dose you're giving at a shorter interval versus the every 6 hours or daily. But keep that in mind. Bumetanide and torsemide, predictable and preferred. Your torsemide now, so this is what I would always recommend. If a patient went home with CHF, if you gained more than, in 24 hours, say 3 pounds, double your dose of Lasix for 2 days and then check your weight to try to prevent an exacerbation. That means you're becoming fluid overloaded. But then I mentioned, okay, well, would we want to increase their dose of Lasix because they might not get the effect because they might be having some GI edematous type issues? True story. So that's when I said, okay, use torsemide instead. But a recent study came out. I think that's been debunked. That was a single center study. I want to see a multi-site. But I'm still a fan of torsemide. When you all do your rotations, ask your provider, what are your thoughts? Who's your preceptor? Ask your preceptor what their thoughts are on using torsemide over furosemide due to very unpredictable variability of absorption of furosemide. I just think we were beat over the head to use Lasix or furosemide, but I want you to keep torsemide in the back of your mind. So we talked about the side effects, the hypokalemia being the main one, the hypomagnesium, and the hypocalcemia. Remember, though, when a patient is eucalcemic, In the distal convoluted tubule, you're going to get the reabsorption of that calcium, so it's not going to be as profound. Now, the ototoxicity, this is going to occur when you have high total doses or large IV bolus doses. And again, we talked about it can have those hairy effect, those hairy cells, whatever, but it is reversible. In some cases, it may be irreversible, but a lot of times the patient has some tinnitus, vertigo, there can be associated ear pain, but hearing deficits can occur. So you need to appreciate that, but that's going to be the high ceiling. That's why they say there's a ceiling, but it's very high. And unlike the thiazide diuretics, which are low ceiling, meaning you can give more if you want to, but you're not going to get any further benefit. So you're just wasting your time. It's kind of like non-steroidals. The analgesic ceiling for ibuprofen is 400 milligrams. Why do we give 800? I don't know. Ketorolac, Toradol, the ceiling is actually 10 milligrams. We'll use 15, but then you'll see 30 and 60. And why? I don't know, but it's just because maybe. But those adverse effects, again, the hypokalemia, that is the big one you need to appreciate and understand. You may have to give supplemental potassium. The hypomag as well, and then the hypocalcemia. Don't be as concerned about it unless it's truly in the setting of hypercalcemia. And then the contraction alkalosis, won't go into a lot of detail that when you have very profound, rapid, aggressive diuresis, you can have large volume diuresis is the way to put it. When you have that, you can have a contraction alkalosis, which is going to show itself or because you're losing a lot of chloride, but what you're going to see is your serum CO2. If you do an ABG, you remember your PCO2, your partial pressure of carbon dioxide is indicative of an acid, and you blow it off, you hyperventilate per se. But in the serum, what you would get on a basic metabolic panel or a comprehensive metabolic panel, that's going to be indicative of the base of your body. So you'll see your serum CO2 jump up. And I don't necessarily think that's something to worry about. You can watch it, but it will come down. That could tell you, though, that you're maybe being a little bit too aggressive with your diuresis and subsequent volume depletion. So maybe you got them where you wanted. Instead of 40 milligrams IV Q8, now you're going to go back to maybe 20 milligrams Q12. So keep that in mind. Some clinical pearls. So Lasix is the most commonly used, the furosemide. Others have more reliable absorption. Remember the hypokalemia. You're usually going to have to give oral potassium, or in the hospital, maybe IV potassium. You're also going to monitor that magnesium level as well. You can get some mild venodilation after immediate IV administration, but remember, it doesn't have a profound effect on blood pressure. That's typically going to be something that that blood pressure is going to be due to volume depletion. If you have loop resistance, so if you're giving someone 40, what you do, if you're giving someone 40 milligrams and they're in the hospital, and first of all, what you do, if they have a home Lasix dose and they're not, and they come in with acute decompensated heart failure, you take whatever their home dose is and you multiply it by 2. I like to do 2.5. If you're going to pull it off, pull it off. Let's say they took 20 milligrams a day at home. Your dose in the hospital is going to be at least 40. And that you might do it Q12, you might do it Q8. It just depends on the level of decompensation. You're going to be checking a brain natriuretic peptide. You're going to have baseline data. There's a lot going on. But if that's not working, we typically say double the dose. So go to 80. So that would be your first double. That's not working. Double the dose. You go to 160. You're getting pretty high now. And at this point, after you do 2 doubles, that's when I would say you may have some loop resistance. This is when I would give the patient 10 milligrams of that metolazone and see if it actually helps or somehow causes a synergistic effect and you start having the diuresis that you wanted to have. Okay. So keep that in mind. Keep that in mind. Okay. Make sure there's nothing I'm missing. Okay. If a patient comes in and they're just having a surgery, they're not in decompensated heart failure, but they do very well on Lasix 20 milligrams per day. Okay. And they PO and they can't take their IV Lasix for whatever reason, or their oral Lasix for whatever reason, because they're nothing by mouth. but you don't want to lose that work, the work you've done to keep them euvolemic. You don't want them to have any type of fluid overload in the hospital. If you were just doing that and they were compensated, you would give 50% of the dose. So if you were doing 20 milligrams daily, I would do, since since it only lasts a couple of hours, I'd do 10 milligrams Q12. But that's if they're not in decompensated. Most of the patients that come in, they're going to be decompensated. You're going to be doubling whatever the home dose is. And instead of daily, probably twice or every 8 hours. But that's the takeaway. But just in case you don't see this as much, but if they happen to, this just gets into F values. But remember, if they're decompensated and you're pulling fluid, I like to go 2 to 2.5, whatever they're taking at home. If they're not taking anything at home, I'll start at least with 40 and see how they respond. So, okay. So we're about an hour and 5 minutes into this lecture. So we're going to keep moving on to potassium sparing diuretics. I want to make sure there's nothing we missed on our, so we talked about furosemide. We talked about bumetanide. Now remember, when you see the lower doses, you could say bumetanide, its ceiling's 10 milligrams. Furosemide ceiling is 400 milligrams. Going back to kinetics, what if I asked you which one was more potent? You would say it takes a lower dose of bumetanide, 10 milligrams, so it's more potent. But which one is more efficacious? Well, remember, it goes back to the equipotent dosing. So that would be a good example that we talk about of the kinetics. I just thought about that. But so, oh goodness gracious, I think we got all our pearls. So let's jump into our potassium sparing diuretics and see where we go to first. Now, remember what I said, for the most part, these are going to be weak and what we call adjuvant, especially when we talk about amiloride and triamterene. Spironolactone, again, has a little bit different. When we talk about a diuretic, it's weak. But when we talk about a therapeutic effect, it decreases mortality in CHF patients. This is high yield. So this might be a good time for you to hit pause and take a 5-minute break, and then we jump back into it, or you jump back into it. I'm going to keep moving forward, but breaking these down. But from a potassium perspective, these cause you to spare potassium, meaning they will raise your serum potassium. So let's get busy. The first ones, your amiloride and your triamterene. Again, remember, these are mainly going to be used as adjuvants. Okay, so they're going to, the amiloride is going to, they're going to be working in that late distal tubule, and I believe they both work the same by inhibiting that epithelial sodium channels in the collecting duct. And remember, where goes the sodium goes the water. So late distal tubule in the collecting duct, but it's going to be the transporter, that renal epithelial channel. It's going to inhibit that. So if excreting sodium, you must retain K. So in this case, to remain homeostasis, this is where you're getting your retention of your potassium. So I would just know where this works and know that it causes retention of potassium, and know it's just adjuvant for those drugs that cause you to deplete potassium. You can give these together and you can mitigate or negate the loss of potassium for the drug that actually has a therapeutic response. So you're going to get a moderate retention of potassium and a horrible increase in urine, or a minor increases. When I say horrible, you're not going to get much of an effect. But you can also, I don't know if I have these in there, but these also will decrease calcium and magnesium excretion. It does increase urate excretion. Maybe it can be used for gouty arthritis. I don't know. These drugs, you don't see them a lot, so not much going on. Not very good diuretics. We will use them in hypertension. We will use them in heart failure, but only add on to thiazide or loops to prevent hypokalemia. Hence why I said these are used as adjuvants. So I think you really need to appreciate that. But so if you see it used in blood pressure, it's usually being added to an ACE or something that's going to cause, a loop or a thiazide to balance the potassium losses versus gain. And that could be hypertension, that could be heart failure. Gosh, I know the lithium-induced, lithium-induced polyureas, I think. Lithium can induce a level of diabetes insipidus. If you don't know that, like a third of patients. We'll talk about that later on down the line. But it can inhibit lithium entry through sodium channels. Okay. Actually, this is very important when we think about this. So, amyloride, that is one thing. I was dogging it. And I think, are we just refer specifically on? I don't know, that might be on there. I want to make sure if we don't have it. So, there's some pearls. So if it doesn't have it on the end, I'll talk about its effect on lithium. I don't want to get ahead of myself, but actually amyloride, when we talk about how lithium can be toxic and lead to uh, diabetes insipidus, that's a polyuria that you can get. It's a hypotonic polyuria is what it is in essence that it can cause. You can actually use amyloride to prevent that. So ascites due to cirrhosis, if you absolutely cannot take a loop diuretic spironolactone, that's going to be more of the amyloride. Okay, so administration, both of the amyloride and tramtrine are oral only. They have a very long half-life. There's really no contraindications other than if someone had pre-existing hyperkalemia. What would I define that as? Usually when they get above 5, I'm hesitant. If they're bigger than or higher than 5.5, I'm going to say avoid that for sure. One thing I didn't mention when we talked about the hypokalemia with the thiazides and the loop diuretic, something you need to appreciate is digoxin. We like to keep our potassium greater than 4. Hypokalemia can manifest or exacerbate digoxin toxicity. If you don't know what digoxin is, don't worry. You're going to learn it this semester, so you'll be okay. We'll go through that. So the contraindications, really none for the most part. Clinical pearls rarely used except in combination with hydrochlorothiazide. Again, there's a product called Maxide and Diazide. That's just adjuvant to offset the potassium depletion of the thiazide diuretic because of the effects of potassium retention by the potassium sparing diuretic. So you do want to be careful using those no sodium salt substitutes because typically the salt, they're still a salt, it's just not a sodium salt, it's a potassium salt. So someone could uh, unknowingly exacerbate or create systemic hyperkalemia, and that can have its own effects, especially when you get above 6. More importantly, when you get above a 7, that's when you start having that QT prolongation and that piked. You'll see a spiked T wave, and that can lead to RNT phenomenons and ventricular fibrillation, and unfortunately death. Death. So keep that in mind. Okay. Okay, go back to amyloride. I told you I didn't have it in there if we did. So you can, when it comes to, I guess amyloride or tramtrine, I'm not sure which one and actually can do it, but you can have effects with lithium. Um, a lithium can have an effect on that convoluted tubule, that collecting duct, that distal collecting duct, and so you'll get a polyuria. You'll make a lot of urine that's hypotonic, and again, as I define that, that would be what we call diabetes insipidus. So it can inhibit lithium entry through those sodium channels. So that right there can prevent that toxicity. Now, whether we use it for that or not, not necessarily, but you may do it. Lithium is an excellent drug for mood stabilization. Now, remember when we talked about therapeutic indexes, lithium has a very narrow therapeutic index. One thing I want to tell you about lithium, and this is very important, I want you to hear what I'm saying. Anything that causes sodium excretion is going to cause lithium reabsorption. So you can increase your lithium levels. So if you're giving Lasix, or if you're giving amyloride, right, you're going to block that lithium. So you need to make sure you have that sodium channel. You're blocking it so you don't get the reabsorption. But when you give, say, like a potassium depleting or something diuretic, like you're losing sodium, it's going to cause you to retain. Anytime, well, forget the drug, whether it's a diuretic, a non-steroidal, if you retain sodium, you're going to lose lithium, and it's a very good mood stabilizer. Choose second or third line because we have valproic acid and some other lamictal, some other projects for that. Products for that. We will talk about it later in the semester, but just know that anything that causes you to retain sodium is going to decrease your lithium. If it causes you to lose sodium, you're going to increase your lithium levels. Just make sure when you acutely add or subtract drugs that do that, you appreciate the fact that you're going to need to monitor the patient's lithium level. That's what I'm saying. Okay, so if you added an ACE inhibitor, you're going to lose sodium, right, through that angiotensin aldosterone system. Sodium and water, you're going to lose it instead of retaining it, where it's going to increase your lithium levels. So if someone was on lithium for bipolar disorder to have mood stabilization and they have high blood pressure, you'd want to appreciate the fact that if you started an ACE or an ARB, because maybe they had diabetes as well, and you wanted that renal protective effect, you'd appreciate that drug-drug interaction. So keep that in mind. Okay, the other potassium-sparing diuretics, from a diuretic perspective, very weak. But the reason I separate these out is because therapeutically they are extremely important. These are drugs that have been shown to decrease the mortality in patients who have congestive heart failure. So we are at the aldosterone antagonists. So on those potassium depleting diuretics, you saw spironolactone. I don't know if eplerenone was on that, Inspira, but we're going to talk about another one called Finerone. But your aldosterone, that is your natural endogenous mineralocorticoid, okay? These do their thing in the collecting duct. So we're on that bottom part. This would be, if we kept going, your distal convoluted tubule would be here, your proximal here, your descending and ascending loop of Henle here. This is where we're at right here, okay? We're at the collecting tubule and duct. This is where spironolactone acts as an aldosterone antagonist, which inhibits aldosterone-mediated reabsorption of sodium and secretion of potassium. So by default, it's going to increase potassium. That's why they call it potassium sparing. It's going to increase reabsorption of potassium, and it's going to increase the secretion of sodium in water. So that's why it's going to have an effect on your preload and to a certain degree, your afterload as well. When someone has resistant hypertension, adding spironolactone to it, try it sometime. And you might see a pretty good looking benefit for the patient. It's not going to be first line for blood pressure. This is what we're going to use, and we'll use it for acne sometime, but this is one of our 4 pillars of congestive heart failure, those being an ACE or an ARB. If you able to afford it, drop the ACE or the ARB and use an ARNI, an angiotensin receptor blocker with a neprilysin inhibitor. It's a combo drug. Those are the pillar number 1. Pillar number 2 is going to be your MRA, that's spironolactone. Pillar number 2 is going to be specifically your beta blocker, such as Coreg or your metoprolol succinate, your long-acting, and then your SGLT2/1 inhibitor. Now you're thinking, I don't know what he's talking about. That's okay. We're not there yet. I'm just letting you know that it's part of a 4-drug regimen that we use. So we're working at the aldosterone receptor. Again, it's going to bind to the mineralocorticoid receptors in the collecting duct and block them. So it's going to block the reabsorption of sodium in water. Easy as that, right? So keep that in mind. So the aldosterone antagonist, so we're going to antagonize aldosterone. Again, what is the endogenous mineralocorticoid in the body? It's aldosterone. If I was to ask you the natural endogenous glucocorticoid, that'd be cortisol. We're not talking about that. So you're going to get a mild natriuretic effect. Some of the sodium is reabsorbed, but not necessarily the water. But you're going to get a decrease in your potassium and your hydrogen excretion. So that's very important. Retention of potassium and hydrogen, excretion of sodium and chloride. And you can get some vasodilation. That's just going to be because you've kind of blunted the response of the renin-angiotensin aldosterone activity. Why is this important? It's been proving to manifest itself in improved cardiac remodeling, left ventricular remodeling, and prolonged survival or prolonging survival in the patient with congestive heart failure. So when will you see these? Well, spironolactone, hypertension, commonly used for resistant hypertension. So I mentioned that as a 3rd or 4th agent. Where we typically use it is heart failure with reduced ejection fraction, not preserved. So it's going to be a HFrEF, not a HFprEF. HFpEF. So heart failure with reduced ejection fraction, typically defined as less than 40 or 35%, in addition to your beta blocker, in addition to your ACE or ARB, or if you can afford it, your ARNI and your SGLT2 inhibitor. So we use it in ascites due to cirrhosis. Typically, you will need higher doses, more aggressive doses, so it can be a drug of choice in that setting. It can be used for primary aldosterone, polycystic ovary disease, and it's used in females with hirsutism, and it can also be used in acne. It tends to work very well in acne. I know my youngest daughter used it for acne, and I thought it worked well for her. So, uh, but anyway, when you give an aldosterone antagonist from an androgen perspective, you're going to have interference with androgen receptor functions. And you're going to increase testosterone clearance and its conversion to estradiol. So just keep that in mind anytime you're doing that. And when that happens, that conversion to estradiol, what do you think one of the main side effects possibly could be? And that's going to be gynecomastia. And sometimes and impotence in men, and that can be a reason sometimes for men not to take it. Now, with women, increase estradiol because women make testosterone as well. You can end up with breast tenderness in women and sometimes menstrual abnormalities. A lot of times, though, these drugs are added later on in life, so just keep it in mind. The whole cirrhosis thing, though, if you're getting an effect with cirrhosis, it's going to be someone, they're going to have a level of nephrotic edema, cirrhosis, the ascites, whatever, but they're going to have high aldosterone levels. So that's kind of what's driving that. And that's where you're going to get that benefit. But think about higher doses for sure. The typical dose is between 25 and 100 per day, but I've seen 300 and higher. Don't be surprised if you see that in your practice when you get out or during your rotation. So keep that in mind. Now, the administration, it's oral. A high-fat meal does increase the absorption. These are all very good absorption from your ADME from pharmacokinetics to appreciate and keep in mind. The metabolism is rapid, is extensive with a short half-life. Sometimes you got to give it a couple of times a day, but contraindications, remember, it's going to raise your potassium. So if someone has hyperkalemia, use it with caution. If they have severe renal impairment, you can use it if their potassium is at a level you're comfortable with and you're monitoring it. The hyperkalemia, again, adverse effect, the gynecomastia, impotence in males, remember again that increase in estradiol from the anti-androgen effect. In women, that can have some menstrual abnormalities if they're still premenopausal or perimenopausal. And then breast tenderness. So, and why is that? You're going to, if you saw a test question, you're going to say that that's because it interferes or it interacts with that spironolactone interacts with the androgen receptor. It's a blocker. So there is a drug out there. You saw it on there. The eplerenone. It is an aldosterone antagonist. Okay, aldosterone antagonist, but no or minimal effects on the androgen and the androgen receptor. So androgens and that receptor thereof, there's not going to be an effect. So what does that mean to you and the patient? This has a lesser incidence of those anti-androgenic side effects that we talked about, so it's more suited for long-term use. So with the women, the menstrual abnormalities, with the breast tenderness, the men, the potential for impotence or sexual dysfunction and gynecomastia. If that's the reason they're not taking it, then by all means, change it. Okay, change it. I think, gosh, I've only seen a couple of patients on this, to be honest with you. I think the normal dose is 25 to 50 once daily or twice a day. I believe I should know that. I know you're a pharmacist, dude. You should know that. Well, if you never see it much, you don't do. I think it might be pricey, but most people do well on the spironolactone. So spironolactone is for all those indications we talked about. I want you to know this. Eplerenone is only used for HFrEF, heart failure with reduced ejection fraction. The lower doses used for hypertension, okay, the higher doses for ascites. And I said, sometimes you might see up to 400 milligrams a day. You're going to monitor their serum creatinine and their potassium and their blood pressure, right? Anytime someone has a change in their blood pressure, especially when they're older, you're going to talk about orthostatic hypotension, and don't just stand straight up. to make sure you don't have orthostasis and have syncope or a presyncopal episode, which could lead to a fall and create some other sequela that you don't want. And then we talked about those no sodium diets where you're using a salt supplement. Those usually are potassium. And then watch for those androgen related side effects that you see with spironolactone. Okay, going to keep moving forward. If you need to pause right here and think about what we just read, please do. We are now at the carbonic anhydrase inhibitors. These are, oh no, I need to find that paper. I have read it. I don't want you to think I haven't read it. It's a paper where they used it in congestive heart failure instead of Lasix. It had some benefit, but not as good. But anyway, if you need to pause here, we started at 2:40 when I started this. It's now 4:04 on a Sunday. So 2:40, 4:40. Gosh, we're an hour and 25 minutes into it. So let's see what we can get with this. This may be a good stopping point for us after here. So the carbonic anhydrase inhibitors, your prototype is acetazolamide. The brand name is Diamox. This comes in an injectable and as tablets. You have one called dazolamide, and there's some others they use. Trusop would be the brand. This is an ophthalmic agent used for glaucoma. So where do these work? So carbonic anhydrase, first of all, what is carbonic anhydrase? Well, you know from chemistry, if it ends in ACE, it's an enzyme. So it's an enzyme, and it catalyzes, carbonic anhydrase does, it catalyzes the reversible reaction of combination of water and CO2 to form what? Carbonic acid. Carbonic acid, what does it do? Think about chemistry. Y'all are going to slap me next time you see me. Carbonic acid spontaneously ionizes to what? Bicarbonate and hydrogen, and that's where we see the excretion of bicarbonate. And one of its benefits, if someone has profound retention of CO2 in the serum, they have such a, for whatever reason, they have a profound metabolic alkalosis. We want to dump it, we can. That's how we maximize the effect for acute mountain altitude sickness or the prevention of it. You want to breathe faster. Well, if we pee off a bunch of bicarb, you're going to have a metabolic acidosis. The only way you can compensate that is have a respiratory alkalosis, and the only way you can do that is breathe faster. So without you knowing, it makes you breathe faster. Maybe just adding 5 to 10 breaths per minute, that might be enough to compensate that lower partial pressure of oxygen that you have at such high altitude. When you're at, and altitude, I think, is defined at 6,000 to 7,000 feet. I never really have effects at altitude. I know at 14,000 feet, the highest I've been, I think, is 14,500. It wasn't Mount Rainier when we went up it. Gosh, I don't know, Pikes Peak. There's been several of them. I'm trying to think as high as I've been. But as far as the height goes, a bunch of 14ers in Colorado. I don't really do that anymore. I learned a lesson that a friend of mine taught me when I lived in Colorado. I was on this thing to see how many 14,000 foot peaks. I think Colorado has 56, but the problem with that was when I was doing it is trying to think all those. Well, anyway, a friend of mine, Lori Maston, she said, always remember life grows on the side of the mountain, not the top of the mountain. Take some time to enjoy the hike. I was trying to bag all these peaks and missing the whole show. The beauty of it is everything that's around it, not on top of it. So after that, I stopped. Just seeing how high I could climb. So, but I've tried it before once and it didn't work. We'll get into it. So where does it work? So it's working at the renal tubular cells, especially in that proximal tubular cell, not the distal. So it's that first part of the kidney. It is right there. So we got it. So proximal convoluted tubule and the lumen of the tubular epithelial cells. And the target is the enzyme carbonic anhydrase that we just talked about. And inhibiting carbonic anhydrase is going to reduce the excretion of hydrogen ions and increase the excretion of sodium. Where sodium goes, water goes, right? Potassium and bicarbonate. It alkalinizes the urine. Now, remember, if someone is on that, this is just a pearl. You're going to use a drug for simple cystitis called nitrofurantoin. when you alkalinize the urine, the effect of that drug, you're going to lose it. So just keep that in mind. That's just something. You're not going to have many patients on this drug. That is not going to be on your test. That is just a pearl. But remember, when we talked about the pKa and the pH, remember the pKa is equal to the pH where 50% of the drug is ionized and 50% of the drug is non-ionized. So if it's a weak acid and it's in a more alkaline base, you can see what it's going to do to that. You're going to have more ionization within the urine. That might come into play if someone had like an aspirin, a salicylate toxicity, if you will. That's not the point of this, but again, it lets us reinforce the things we taught that you might not think are important. Even when someone makes the comment, I don't know why I got to know this, it's not important. Well, what I just told you was general chemistry. And if you're going to work in the ED and toxicology, what I just said means something. If you understand that conceptual process, you're going to understand the processes of the human biome or the human pathophysiology, whatever, not the biome, that's bacteria, but how a human body works, right? It's very important. So with that said, you're going to, inhibit in that proximal tube. And again, it's lumen and tubule, or someone say intracellularly if you want to use that word, or the tubule apical membrane, however. But you're going to get an increase, you're going to get a decrease in that availability of hydrogen ions to exchange with sodium, right? So you're going to have increased sodium bicarbonate excretion with mild natriuresis. So I want you to appreciate mild. You're not going to get a profound diuretic effect when you do that. Now, you can get inhibition of carbonic anhydrase in the CNS, which leads to a decrease in cerebral spinal fluid and a decrease in firing from neurons. That can help if someone has acute mountain sickness, not prevention of it to help you breathe faster, but if that's someone who had acute mountain sickness, that would be its mechanism right there. I'm not going to go into that much detail on your testing, but though some of you somewhere may work in some type of environment in Vail, Colorado, in Aspen, Colorado, or somewhere where there is altitude sickness, and Texans that go from 10-foot elevation in Houston right up to Steamboat Springs at 7,000, and they have issues with it. But then, so just keep that in mind. Okay, so as we move through the therapeutic uses, IV, oral, ophthalmic, we talked about the high altitude sickness. Now, to prevent it, we're creating the metabolic acidosis with the compensatory respiratory alkalosis. I told you how it works when we talk about the CNS. So that's going to be, again, that decrease in production of cerebral spinal fluid by inhibition of this is all through the inhibition of carbonic anhydrase. So, and also that decreased firing of neurons. When you decrease the firing of neurons, what are you doing? You're decreasing O2 consumption and you're not having as much energy. So that's a good thing. The glaucoma, that's going to pretty much be the topical alternatives. It's going to reduce the aqueous humor by blocking production of it, not drainage, or increasing. That's going to block carbonic anhydrase in the eye. Okay, so it's going to decrease aqueous humor formation, okay? The formation of aqueous humor, not the increased expulsion of it. There's difference when we do that, okay? And you'll learn that when we talk about glaucoma, but the end game is a reduction of intraocular pressure. This is a third line agent. Our first line agent is prostaglandins, and then second line beta blockers, or a combination of the two. Then we go to the carbonic anhydrase inhibitors and alpha type drugs. So keep that in mind. Others, it can be used in epilepsy for just what I explained of the CHF, correction of a metabolic alkalosis, right? We can use it sometimes for a respiratory stimulant in COPD. That would be the same mechanism as this right here. Adverse effects, the drowsiness and the paresthesias are very common. This can be debilitating. The time I took it and my wife took it, when I say pins and needles, it was everywhere. It was horrible. You can get a hyperchloremic metabolic acidosis. Remember, you do have potentially, you're going to lose potassium. That can lead to hyperkalemia, and then potential skin reactions up to the toxic dermal necrolysis or Stevens-Johnson syndrome. So, and then decreased excretion of your weak bases, pseudoephedrine, amphetamine, quinidine. Think about the pKa and things like that. Clinical pearls not commonly used except short-term situations. Critical care, you'll see it given IV to compensate for contraction alkalosis with aggressive loop diuretic, right? Therapy, and as a respiratory stimulant in obesity with hypoventilation. You don't want to overcorrect acid-based issues, so be careful. Look at your ABGs and your chemistry panels, and then you certainly want to watch for changes in eyesight and hearing if you're on these drugs, and then kidney stones are potential long-term effects. So this is where we're going to stop. That was diuretics. I want you to think about this. How long did we talk about that? We went 2 hours and 20 minutes. We went from 2:40 to 3:40 and then to 4 p.m. So we went an hour and 20 minutes, and then we went an hour and 34 minutes. So when we come back, we're going to start with week 3. So this is going to be the end of week 2, lecture 2. We're going to start with water homeostasis, okay? And this is where we get into words or topics such as diabetes insipidus, or syndrome of inappropriate antidiuretic hormone. That's when we get into that. So a lot going on, but that was your lecture on diuretics. And if you have questions, get with me sooner than later. We can do a live Zoom chat or a discussion over the phone. And I have some other illustrations and teaching points. So anyway, very, very high yield discussions when we talk about this. Not so much with the water homeostasis, but right after that, we're going into the renin, angiotensin, aldosterone system. And that is very important, very important. So anyway, that ends week 2, lecture 2.